I'd like to invite the entire panel to address, we've received many questions from the audience. So I'd like to invite you all to share your expertise on some of these questions. And one of the first ones, and I know we had one from an earlier panelist regarding the thresholds for invoking crisis standards of care may be perhaps too high. Maybe what are the barriers in having state and government leaders declare crisis standards? And I don't know that we are at liberty to be able to address that here. If any of you have thought about that, I'd love to hear the answer. If not, I think we will be having another panel discussion on that topic. But does anybody from the panel want to have an idea about that? Okay, let's talk mainly about staffing. There was an interesting question. Solution was increasing the number of nurses and new nurses and graduates, but aren't we putting them into the fire, into the same environment that's causing current staff to leave? Any thoughts about that? Perhaps Dr. Rowan?
Sure. I think that the biggest reason that staff are feeling demoralized and burned out is a lack of staff, a lack of team members to share the burden of patient care with them. And when you think about nursing, it's a 90% female workforce. About 70% of nurses in the country have children or parents that they're caring for. And the COVID crisis really pushed those two things. We also saw early retirement of nurses, and in particular, the baby boomer generation. And we saw nurses leave for other types of nursing care provision outside of a hospital. But what I believe really decimated the nursing profession related to staffing is the travel nurse industry. And because the travel nurse industry and agency nursing companies were able to push the rates for nurses as high as $275 an hour to a hospital. So the nurse doesn't make $275 an hour. The nurse makes about 2/3 of that. But just imagine if you are working at a hospital making $60 an hour, and now you have an individual who's working side by side with you and doesn't even know your patient population the way you do, or your hospital the way you do, or your electronic record, or how to access the Pyxis. And now and you're orienting this person who's making 3 times your hourly rate. And that is, in my opinion, the biggest foundational reason that the workforce became decimated, because so many nurses followed the money. I don't blame them, by the way. What I blame is that we have allowed this to happen. I blame us or our government for allowing these rates to be charged and for seeing this mobile workforce really just pull hundreds of thousands of nurses out of acute care settings where we need them so desperately. I do believe if we graduate more nurses and get them back into our acute care settings, it will do what it's done in the past when travel agencies have pushed these rates, and that is the opportunities for travel nurses dry up. And so nurses stay at the bedside, and that changes the culture within, because you're back in a team. You're feeling like you have a team that is functioning together. So that is why I believe that graduating more and hospitals helping schools of nursing to graduate nurses more by funding more clinical educators or clinical instructors to bring more clinical practica into our settings will ultimately solve this dilemma related to getting the team back and re-engaged.
Thank you, Dr. Rowan. As an offset to that, and I've worked with many of the travelers during deployments, and this is also going to pertain to our EMT workforce as well as our physician staffing. Early in the pandemic, many were sidelined, given papers, furloughed, not paid, and that's what drove them into this creative travelers, other type of workforce. So perhaps the early responses by hospital systems or leadership did help with this certain situation, and some, which turns us to another question: is the healthcare workforce lumped in like a ventilator as a resource that then can drive into crisis standards of care? Is that the right way to be thinking of our staff as an expendable resource? And that is a question that has been posed to this panel. What about this terminology, and what are some thoughts, and is that contributing to some of the moral injury and burnout?
Yes, I can take that. I think the obvious answer to that is that human beings are more than just a resource. And we talked last hour about the importance of interprofessional relationships, understanding roles and responsibilities, and experience together to really put together a high-performing healthcare team. And I think that those concepts cross the gap between the bedside and the digital healthcare environment that we've described as well, in terms of some of the innovative ways that we are trying to expand our resources and abilities there. I think human beings naturally are going to look for personal security and security for their family first. And I don't think that those principles are unreasonable in terms of a core value that healthcare organizations should think about, to retain highly skilled individuals who are skilled and seasoned at performing within their healthcare environments. And without that, what you will see is loss of manpower in individual organizations, and that constant turnover and churn, any CEO knows, creates significant excess cost, and it degrades overall workflow and quality. And that's things that we all want to combat.
Thank you very much.
I would add that
Yes.
the healthcare, resource, if we're going to use that term, also has to be added to the digital system, and it has to be trained to use this very complex system to navigate. And so, and that training, it became pretty critical, no matter who was added to the system, to be able to make sure that that person knew how to use. And when I describe system, not as only the technology system, but sort of the system of care. Rather than having to rely on somebody who knows that system, who's already busy, having a mechanism, an automated way to be able to get them trained. That was another thing that we found was an offset, is all the electronic learning tools, just to be able to bring that person up to speed in terms of how the system functions.
Thank you. One question that is coming up a lot is funding. Dr. Backer mentioned what California can do, but are there any thoughts have you for staff?
Sorry, Asha, you broke up a little bit. I'm not sure if I fully got the question.
Yes. So one question that is, Dr. Backer mentioned, California can pay. And how has funding become a challenge? What are some thoughts there in terms of staffing solutions? And I know Dr. Rowan had mentioned kind of some uniform criteria. What are some concerns there? And I think USA Today had published something on the travelers nurses situation, and if anybody wants to address that topic.
I'm sorry, I still don't fully understand the
So-
question.
So the disparity, yeah. Oh, sorry, Lisa. The disparity in pay.
Yeah, so I think that the disparity in pay is problematic. And, you know, when we look at what any team member in a hospital gets paid, we can look at it nationally and regionally. And that's what our human resources colleagues do. They look at what the competitive market is that we're all looking at. Clearly, the travel industry is well outside of that. And as we pay more of those high rates, what it does is it pulls away from what we can do for our own team members related to their pay rates, related to their benefits. And so it's really directing a huge amount of hospital funding toward this mobile workforce that will be gone very soon, instead of our own workforce who's stayed, who's been loyal, who's committed, and really who we want to reward. So it's problematic.
Asha, if I could make a few comments on just kind of staffing and issues that we found. One is that there have been several mentions about the importance of forming highly functional teams. And whereas it's clearly optimal to have a long-term stable workforce staff, in a disaster, you have to be more creative and bring in staff from a whole different, from many different sources. And it may be, you know, national or state supporting locals. It may be the military or National Guard supporting. So I think that there's a part of some of this needs to be part of our normal our daily options, because the fact is that our healthcare system's under stress at the best of times, and it doesn't take much. All it takes is a flu season to overstress our hospitals and require tents, additional staffing, and a lot of the surge measures that we pulled out for this pandemic. So what we found in California, which was interesting, was that during the first wave or two, the state really supplied all the staffing and covered all the costs for the hospitals. Then we tried to wean them off the state dependency and say, okay, well, you just go to contract agencies and hire extra staff yourself. And there was a lot of resistance to that. They really had kind of become dependent on the state resources. And so we had to wean them off of some of the supplies or resources, including staffing. The one other point I would make is that, you know, we substituted, or we had different compositions of teams. And in California, and I think this was mentioned by Dr. Garrett, that EMS personnel are a really good way of supplementing healthcare teams because they're quite flexible. We found that paramedics complemented nurses. They couldn't replace them, but they had certain skills that nurses didn't, and vice versa. And working together, they were really very good in an acute care setting. And EMTs could, you know, if we couldn't get an LVN, we could use an EMT, although again, their skills aren't perfectly equal. But there are, we can use more different mixes of people to our advantage. But unfortunately, once we go back from our crisis and contingency care to our standard care, then often the exemptions from regulations go away, and the territoriality of our professional societies and unions come back and say, oh no, you can't bring these people in, we don't want these people supplementing our staffing. So those are some of the challenges I think that we have in terms of utilizing these creative solutions over the long run, and that relates to an issue that you brought up earlier of triggers of crisis care. Maybe it shouldn't be such a trigger that's so far to the extreme. We need to be able to use this spectrum much more often in our healthcare system.
Thank you. That's a very important point. And I think that's something that one of the questions had raised, is that should we move the bar a little to the middle before we call it crisis? And I think that's an excellent comment for this panel and for this entire lessons learned workshop. Another question that you actually posed in the chat, and we will probably address it at the end as well, is which of the changes in healthcare currently that you have made at your institutions as a group should remain permanent? I invite the panel to give us one sentence or a one idea remark on that one. Who wants to go first?
We during the crisis, we changed what was expected for documentation and moved to an exception charting. So you assumed everything was done. You assumed things were okay with the patient unless it was documented that they weren't. So it was by exception. That really flipped how we document on its head. And takes a lot of time to do the old way of documenting. And now we're moving toward making this our standard practice now.
I think the patient expectation changed significantly. There's no putting the genie back in the bottle when it comes to virtual visits and virtual care, and the ability, the convenience associated with it, the reduced cost associated with it. So I think that's going to be something that we'll see persist. Likely there'll be some impact of ongoing legislation around the rules in terms of what you can and can't do for patients that have virtual visits and so forth. But that idea that we stole from the consumer industry, the retail industry, the travel industry, and applied in an appropriate way in the healthcare space. To basically be able to let patients self-serve, let patients find out what's going on, be less of a black box to patients, and then be able to make ourselves available at their convenience, at their schedule, at their location, at their cost. I think that's a good change that should persist.
Yeah, from our standpoint, I think we broke down a lot of silos when it came to staffing individual work areas, both within our institution and also healthcare and patient allocation within our region by developing systems that allowed us to track and reallocate patient and workflow, so that we would maximize the capacity and capabilities of the system, both within and outside of our organization. I guess the second thing that we recognized, especially in our COVID ICU, is that the bedside care, especially with all the PPE demands, has been extremely hard. And so we've actually leveraged the increased need and demand for electronic health resources as an opportunity to rotate staff and expand our pool of staff who engage in those services, to give them a break from the bedside and the N95 mask.
I
Thank
would
you,
just,
Alex.
yeah,
yes.
I made some comments on this in my previous comments, so I'll be brief, but I think that the long-term nature of this response has really ingrained the emergency management concepts and practices deeply into the healthcare system, so that not only do the health systems and facilities know how to go into emergency management mode and where to get and how to get resources and how to request resources. So I think that that is something that is always supposed to have been permanent, but really wasn't optimally utilized because our disasters were always seen in very short-term localized mode as opposed to chronic and generally diffuse widespread mode. So I think that will be a permanent benefit from this response.
I would add that at our 13 hospital system, we've really focused on team member wellness throughout the past 20 months, and it has been appreciated. We've also focused on our management and leadership teams related to that, and that will be something that continues. The focus on wellness and our team members' health will be really front and center, I think, moving forward and hope forever.
And I think that is reassuring to the audience to hear, because that is many of the questions asked for tips regarding wellness and prevention of moral injury and rotating staff out of the COVID unit. So I thank you in your comments for addressing that. And it's nice to get a sense that we're not, hopefully not going to return to business as usual in many aspects. And I hope from your comments that leadership at all levels will continue to address this, because I think burnout was already a topic of interest prior to the pandemic, but now it is front and center. And in your last, we have a last 2 minutes. Any last minute thoughts, one concluding statement from each of you?
I can jump in and highlight one gap when it comes to understanding moral injury and burnout in healthcare workers. There is practically no data out there when it comes to respiratory therapists, EMTs, and other allied health professionals. And that's something we need to understand and measure if we're going to look for solutions to address it.
I think we've all come to learn that healthcare is so very labor dependent, and yet there are some processes that are amenable and poised for automation. So I think this can be seen as a shock to the healthcare system, and what's incumbent upon us is to learn which aspects of the workflow can be automated and how can the patient participate in their care, and how do we do shared decision making and self-serve to be able to ultimately meet their needs as a way to decant off of that labor, but also sort of make it more consistent, reliable, and remove the unwarranted variation in care that we see.
I think we have a duty to partner with our schools, whether it's nursing or medicine or respiratory therapy, certified nursing assistants, to partner with the schools differently. Because as we integrate those individuals who are in school, in education, in our clinical settings, and partner and support them financially, we can change the model of care to be something different moving forward in the future that becomes more sustainable, so that the students get a better education at the bedside versus in a sim lab. And we have a way to support the human need within our settings to care for patients differently.
Well, and we certainly learned that, you know, you can have the fanciest facility and all the resources, but if you don't have staff, you're not going to have healthcare. Um, you're not going to be able to provide healthcare. So the staff is the number one element that you need for healthcare, and you can provide healthcare in any kind of situation, you know, whether it's a tent or a gymnasium or a hospital. And you can move around ventilators and equipment, but you've got to have staff. And I think that we found that healthcare personnel are totally committed to their profession and were able to accomplish amazing feats under stress. And we really need to take care of them, as the other panelists have noted.
Well, thank you all for this amazing discussion and solutions that you've shared with us, and also highlighted some things that need to be considered going forward for the Crisis Standards of Care Committee and going forward.